Good morning everybody. OSCE with Vimal എന്ന എൻ്റെ ചാനലിലേക്ക് സ്വാഗതം. ഇന്നത്തെ ടോപ്പിക് ഓഫ് ഡിസ്കഷൻ ഈസ് നമ്മളുടെ റാപ്പിഡ് ഡിറ്റക്ഷൻ ആൻഡ് റെസ്പോൺസ് അഡൽട്ട് ഒബ്സർവേഷൻ ചാർട്ട്. ഓസ്ട്രേലിയൻ നോസ്കി സെനാരിയോയിലെ റാപ്പിഡ് ഡിറ്റക്ഷൻ ആൻഡ് റെസ്പോൺസ് അഡൽട്ട് ഒബ്സർവേഷൻ ചാർട്ട്. അതാണ് ഇന്നത്തെ ടോപ്പിക് ഓഫ് ഡിസ്കഷൻ. So this chart is used for recording vital signs and A to G assessment. So how you are going to assess A to G, that I have discussed in another video, and vital signs also we have discussed in another video. If you haven't seen it, please go through the video. That's in my YouTube channel there. On top of that, after finishing their vital signs or A to G assessment, they have to go for a vital signs, that's charting. They have to chart the vital signs in this chart. So in UK scenario it's called a news chart, National Early Warning Score chart. Then Irish scenario, this is called use chart, that means early warning score chart. Okay, the same thing is small bit difference in the Australian scenario, where they will talk it as MR59A, that is rapid detection response adult observation chart. So today we are going to discuss about rapid detection response adult observation chart. So those who are looking for Australian OSCE training, those who are looking for Australian OSCE, this will be very helpful for them, because I am getting a lot of requests from so many of my followers about to do a chart assessment over here, so that they can familiarize with the chart. So today we will see what's going to happen in case of how you are going to record this National Early Warning Score as per rapid detection response adult observation chart, and how you are going to escalate the plan. Okay, so the important point you have to keep in mind is there are two pages will be there. So this is the first page, that's called rapid detection response adult observation chart, and these are the guidelines over here. You can see the guidelines. Section A is there. There are certain guidelines will be given for you, and then how you have to fill up the section D, that's here. Then a change of frequency observation is here. Then interventions and review is here, and the next one is section B, that is a resuscitation plan. Whereafter you will be going to section G, you can see the medical emergency response call plan, and multidisciplinary team review plan, and registered nurse, registered midwife review plan, and section H is called sedation score. And on top of that, in every station, my request for the students is you have to fill up these things. Okay, they see the demographic data over here. So this is the first part, and the second part on the other side is this is the portion where you are going to fill up the vital signs over here. So you can fill it up over here, and then you have to coming down to the lower part, there is an escalation plan, that is the signature is here. So this is the signature over here, can show you the signature, and thereafter on the other side there is a modification plan, it is here, and changes to the usual frequency observation, that's here, and interventions and review, that's done, that's over here. Okay, so these are the important points you have to keep in mind. So now we will discuss how you are going to chart this observation chart. Okay, that's adult observation chart, and plan accordingly, so escalate the plan. So for example, you are going for a vital signs, or you are going to go do for an A to G assessment. In both scenarios you have to do a vital signs. Vital signs in the Australian scenario for general public, it's generally called observations. So you are going to do the observations. Once you have done the observations, either the examiner will give you a list of readings, or the examiner will read you then and there the readings will be given for you. Okay, so whichever it is applicable, your job is you have to fill up the observation chart and escalate the plan. So we will see how it's going to happen. So the first we will look into the section C. So this is the observation chart. So what you have to do is you have the year is here. For example, if this is a 2013, you can write down over here, and there is a date column is there, there is a time column is here. Okay, and on the other side there is an MER call, that is a purple, and the MDT is the red column, and the RN/RM is the yellow is there. So which one is applicable, you can tick in. That later I will tell you how you have to do that. So for the first chart column is respiratory rate, oxygen saturation, oxygen flow rate, delivery method of oxygen, blood pressure, heart rate, temperature, and coming down further down, it's a sedation score. This is quite similar to the AVPU score in the UK and Irish scenario. They figure it out as sedation score. And then new and unexpected pain score. That's if it is there, you can record as Y. If it is not there, you can record as N. Then the regular pain score and the initials. Okay, this is where you are going to do it. Now we will see what's going to happen. So you have to put up the date and the time. So that the respiratory rate, first we will look into the respiratory rate. Respiratory rate is the lowest is 7, then 8 to 10, 10 to 15, 16 to 20, 21 to 25, 26 to 30, 31 to 35, and 36. So here you can see there are certain white zones will be there. This is the white zone indicates that's quite normal. Okay, there is no escalation is going to happen. White zone that looks like it's okay there. So red zone on the both sides, example 21 to 25 and 8 to 10 is a red zone, and further down there is a purple zone, and then is going to the pink zone, and the purple zone is over here. Okay, sorry, red zone and the purple zone is over here. So you chart the example, the patient is having to be a respiratory rate of 26, so you are going to put a dot over here. In Australian scenario, what's going to happen is if you are putting a dot, a single dot like this, they won't accept it, because you know the white population, they like a dot to be filled in like a big dot like this way. So the students always make sure that the dot they are putting is a big dot. The examiner is also not going to put any effort to read your technical details or your whatever you have documented. So it should be legible and it should be clear for the examiner, because they are not going to put any extra effort over there. Okay. The other point is come down to the oxygen saturation. So for example, see the oxygen saturation, there is a white zone is here, that's 95 to 98 is a white zone, 90 to 94 is in yellow zone, and coming down there is a red zone and a purple zone over here. Okay, so you have to, for example, the patient is having a 96 oxygen saturation, you have to put a dot over there. That's already done. And this patient is on oxygen, so here what you have to do is you have to, if the patient is on oxygen, that is liters per minute, so you have to write down. If it is more than 8 over here, 7 to 8 over here, and 5 to 6 over here, and 0 to 4 over here. So my patient is, imagine this patient does not have any oxygen, so leave it. Then oxygen delivery method, so example, if the oxygen delivered through nasal prongs, NB you can write down, mask you can write down, so you can put it over there. Okay. Next, coming down to the next aspect is the blood pressure. So blood pressure you are going to assess once you have done the blood pressure, you have to record that. So it's an inverted V. So this is the way you are going to assess record the blood pressure. Okay, and dotted lines over here. So example, the patient's blood pressure is 70 over 150, so you are going to record this way, and you are going to take this is the portion where the white zone, that's okay there, yellow zone bit up and not okay, and the red and the purple means there is a huge problem that's there, so you have to look in for emergency medical team to come in. Okay, next we will look for that I will discuss once you are coming to the whole topic. Okay, heart rate. Here is this example, this 60 to 90 is okay there, there's no problem over there. This is the yellow zone where the nerves have to come in, and this is the red zone, and the purple zone is here. Likewise on the downstairs is there. I forgot to tell you something, when for the blood pressure assessment for escalation plan, we are going to take systolic BP. Use systolic blood pressure as a trigger for response. Don't take the diastolic one. The diastolic is whatever it is, just leave it like that. Okay. Next one is the temperatures. So temperature is also same story. 38 up to 38 is okay. Above 38 is a fever. Okay, and come down 36. That's 35.6 is the minimum. That's over there. That's in the white zone, and further down it's yellow zone, and further down it's a red zone. Further up here over here, it's a red zone. That's continuing. Okay. Next one is about the sedation score. Sedation score, what's going to happen is 0, 1, 2, and 3. Okay. So I have to explain about sedation score. In order to explain sedation score, I'm going to the next page. So here is you can see the section H describes sedation score. Sedation score, what's going to happen is you have 0 score, 1 score, 2 score, and 3 score. Okay, and this is the score side, and descriptor is here, stimulus is here, response is here, duration is here. So you will see what's going to happen. So you are going to approach the patient, and the patient is talking to you, interacting with you, and patient is oriented time, place, and person. Patient is perfectly okay there. There is no stimulus needed. to talk to you, and there is no special response, and there is no duration. That means patient keep on interacting with you, in which that's why it looks like quite okay there, in which you are going to score 0 over there. Okay. The next one is when you are going to approach the patient looks sleepy. Okay. So you are going to do is you are going to use a voice. That means call the patient by patient's name, or call the patients by hello or hi or whatever it is. So that's it. Or on top of that, you will be using a gentle touch. So voice with a gentle touch, you are going to approach the patient. So here what's going to happen is when the patient is opening the eyes, patient was sleeping at this stage. Now patient is opening the eyes, maintaining eye contact with you. More than 10 seconds, the patient is talking to you, interacting with you, and patient is oriented, time, place, and person. It looks okay there because the patient is a bit sleepier. That's it. So here is you are going to record as 1. Okay, 0 and 1 is in white zone. Okay. The next one is you are going to look for the patient who is sleepy. You are going to approach the patient with a voice and light touch. You apply the same way, and patient is awaking but very difficult to arouse. That means very difficult to sleep. Further sleep is there. Difficulty in staying awake. That means patient is opening the eyes, but he cannot maintain contact more than 10 seconds. So the contact will be less than 10 seconds. Patient is closing the eyes because patient looks sleepy and tired over here. So there is some problem over here. 2 is the score you are going to score. Next one is these two things are not working. Now what you have to do is you have to apply. That means voice and gentle touch is not working. Patient is still sleepy over there. Patient is sleeping, or patient looks like sleepy. So you have to apply pain. Okay, there are 2 pain scenarios you can apply for the patient, but in case of Australian scenario, you are going to use a trapezius muscle pressure. That's okay. That's called shoulder squeeze. That's on the back of the shoulder muscle, between a shoulder and on the back of the shoulder. There is a muscle on the both sides of the neck. That's called trapezius. So you are going to apply pressure of trapezius, squeeze the trapezius. Now patient here also, patient is making a brief opening, but not in a continuously keep on going with your contact. That's not happening there. And a momentary opening, and there is sometimes there is no response. There is no duration there, just opening the eyes and closing, and sometimes not opening the eyes and closing. So here is difficult to arouse you, so you have to start 3 over here. So this is the way you are going to score the sedation score over there. We'll come back to the vital sign sheet again. The next one is that we have scored. For example, patient is talking, interacting, and everything is okay there. So you are going to score 0. Next one is a new and unexpected pain. New and unexpected pain means a patient is going to get a new pain. Okay, and you are going to assess the pain, and the patient's score is between 8 to 10. Now your job is you have to reassess the patient's pain in another 1 hour time. That means within 1 hour time. So if it is again between 8 to 10, so you have to write down yes, this is a new or unexpected pain is coming up. That's called yes. But here my scenario, there is no new unexpected pain, so I am going to write n over here. Okay, if yes is means there is a new unexpected pain is coming in. That means the 2 readings you are going to take 1 hour interval. So in which the readings will be between 8 and 10. Okay, so in that case only you can write yes, otherwise no. Next one is the normal pain score. Okay, so the pain score you are going to once you are approaching the patient, you will be assessing the pain score 0 to 4, 5 to 7. That's okay, and 8 to 10 is yellow zone is over there. So once you have done, you have to go for the signing over here, because everything has to be signed. Then only it is considered as a document. Then on the other side, you can see these are the demographic data. The universal registration number, surname, given name. Surname means the second name, and given name is the first name. And there is sometimes second given name will be. That's also you can record over here. Date of birth is there, sex is there, hospital is there. Next one is section D. There are certain modification can happen. So modification means I will tell you what's going to happen. So for example, the patient is now you feel that the patient's blood pressure is very high, or patient's respiratory rate is very high, or the patient's saturation is not good enough at the moment. You feel that it's okay there, but you are trying to improve by you are putting some measures over there not to improve the patient's saturation. So in that case, what's going to happen is if you are calling the patient and the doctor every other minute, that's a nonsense. So in order to correct that, there is a modification a doctor can make, a consult doctor can make for 24 hours. This is maximum for 24 hours. If this modification goes beyond 24 hours, a consultant has to sign. Okay. So a doctor or a RMO or a senior or a junior doctor can sign it, but it's not a consultant. So here you have to write down what is the modification to the example date and the time you have to put in. So example, this is the date and this is the time. Time is around example 10 o'clock, and then even the closing time is 10 o'clock. Then now I am going to make a modification the blood pressure. So usually the triggering factor for blood pressure is, so for example, the blood pressure for triggering factor for the Mercol is 180 and the MDT call is 200. Okay, so what I am going to do is I am going to keep this call to the 200 and 220. Okay, so if it is instead of 180, I am going to put it as 200, and instead of 200, I am going to put it as 220. Okay, so 20 I am going to include because I know this patient is having a high BP and patient is I am trying to settle the patient. It will take a while to settle the things there. I am not going to get a quick fix for this patient at this moment, and it will take a while to come in. So this is the modification in which the doctor can make, and when doctor has to sign and doctor has to put his name and designation. The other problem for this modification is the nurse have to sign it in a signature, name and designation has to put in, because nurse should be aware about this modification, then only the modification will work. That's all. That's the reason why the nurse have to sign the modification, then only the modification will work. That's the policy of Australia. Okay, and the other one is if the modification is going beyond 24 hours, a consultant has to sign. Instead of a doctor, the consultant should be over here, and you can modify different parameters. For example, you are modifying BP, you can modify respirators. For example, COPD patient, the breathless. Okay, and you are trying to bring the respiration down. It will take a while to come down, so you can modify it. So if, for example, you can go for temperature to modify. Patient is having fever, you are trying to modify, it will take a while to come down, so temperature you can modify. So likewise you can modify all these things. Okay, then next one is section is changes to the usual frequency of observations. So for example, you feel that the patient is not great at the moment and you are trying to manage the patient. There is no need for continuously going behind the patient to do the observation. That is going to affect the patient's comfort. Okay, so here you can change the frequency of observations because you feel that the patient is that is needed. That frequency is only needed for the patient at this moment. So where you can change a usual frequency observations. So when you are going to make a change in the observations, for example, new frequencies, for example, you feel that the patient is not doing well, so you have to increase the observation. That you can write down over here. Instead of 12 hours, you are going to go with the 6 hours. Or otherwise, there are certain scenarios in which a patient is okay there, and you are going to bring down the observations from 12 to sorry for that, and 12 to 6 you can also go back on the other side as well. So that's also possible over there. Then so this type of changes you can make, the reason for change and finish date and time, and the name and signature and designation should be there. Okay, next one is section F, that's the intervention or review date. So the point is there is an MDT or MER call is going to take place there. They are coming over here and they are going to do some discussions, or they are going to give some suggestions, especially they are going to look into urine output or increased frequency observations or blood glucose or oxygen changes. Some changes they are going to make, so you have to put a date and time and you have to make that changes over here, what they have changed, what they have done at this stage, and what is the reason for MET or MER call. It can be patient concern, physical state changes, mental state change, and put your name and designation over here. So that's the way you are going to fill in the section F over there. Okay, on coming to the other side, so first I will look into the escalation plan. So this is the escalation plan. So we have just see what's going to happen is so this is the yellow zone. There is a one of my reading is in yellow zone, and there is coming down further there is an yellow zone reading is there. So 2 of my readings are in the yellow zone. Okay, and we will see what is going to happen. So in case of yellow zone, you have to escalate the plan. So escalating the plan means you have to talk to the patient. So for example, patient's name is Mary. Mary, I have done your observation. I have done your observation chart, and it looks like there is 2 observations in the yellow zone, so I have to call in for my nurse to come in. Okay, so that's the way you are going to talk to the patient. And also I am going to increase the observations to every 4 to 6 hourly. So you can take out one observation 4 hourly or 6 hourly. So I am going to take it for 4 hourly. And also I'll stay with you to control to reassure as a reassurance for you. And also I will keep an eye on your pain and oxygen saturation. So this is my plan. So likewise, you have to talk to the patient about the plan. So how you are going to do that? We will see. Registered nurse or registered midwife to come in case of yellow zone. Okay, so yellow zone, now see, one or more of the observations are in yellow zone. Say in our scenario there are 2 observations in the yellow zone, so we have to call in the nurse to come in, okay, or a senior nurse to come in. Or else you are worried about the patient, or the consumer is worried. Okay, that's another story. And on top of that, there are the other criteria as well. New or unexplained behavioral change, intradialysis BP drop of more than 20 mm of mercury from baseline. For a review or unexpected pain of 2 scores of 8 to 10 within 1 hour, senior nurse to review and to consider MDT review if required. So these are the points you have to keep in mind if you are looking for a nurse call. Okay. Once the nurse is here, what you have to do is the nurse have to look in and come in within 30 minutes. That's very important. And also nurse have to escalate whether the MDT is needed or not. That is the second point you have to keep in mind. Then frequency observations has to be decided. Probably it has to be increased to manage anxiety and pain at this stage, and keep an eye on SpO2 and oxygen saturations. If a new or unexpected pain that we discussed previously, 2 or more consecutive pain score of 8 to 10 or within 1 hour, senior nurse to request MDT review if required. So if there is a pain is coming in between 8 to 10, the 2 readings 1 hour apart, so you have to go for MDT review straight away rather than keep on going with it. So nurse will be coming over here. She has some responsibility. She have to take some decisions over there. So these are the decisions she is going to take. So in scenario, what's going to happen is you have to talk to the patient. So this is the plan for myself over here. Okay, so that's the way you are going to do that. Then the next one is escalate MDT review if 3 or more observations are in yellow zone. So I was talking about 1 or 2, that's okay, 1 or more. But if it is 3 or more, straight away go to this side. Okay, so here what's going to happen, if 1 or more observations are in the red zone, or 1 or more observations for the following are occurring. So 1 or more observations are in red zone, straight away you have to go for multidisciplinary team review. Or you are worried about the patient, or the consumer is worried. So the next one is the 1 or more of the following is happening. Unrelieved chest pain, urine output of less than 30, over 4 hours from the patient from the IDC, or patient has not voided for over 12 hours unless intradialysis, delayed R and RM review. That means you call the nurse is not coming in for 30 minutes, you have to go for straight away MDT review. And also escalate if 3 or more aspirations are at zone. So for example, 1 or 2 is in this one, you go with this way. 3 or more, go this way. Okay. Then once over here, what you have to do is, that's the next point. MDT review must occur within 30 minutes. Okay, if it is not happening, you go through MER straight away. County hospitals are referred to the local guideline because Australia is a big country, and sometimes in the community hospital or county hospital this is going to happen there. So in that case, you have to look for local guidelines or escalate to the MER call. This is the MER call over there. Increase frequency observations to hourly. Escalate if there are ongoing fluctuations. Review SpO2 or oxygen for flow rate requirements. So for example, this is the scenario that you are going to get. So what you have to talk to the patient. Okay, patient's name is Mary. Mary, I have done your observations, and I have calculated your observation score, and so the score looks like 2 of your readings are in the red zone. So my plan is I'm going to conduct for an MDT review. So they are coming in 30 minutes. So until that time, I will keep an eye on your observations. I will increase your observations to every 4 hourly, and I will keep an eye, and if it is needed, I will go for the further. If any fluctuation, I will go further increase to continuous monitoring. Okay, and I will keep an eye on your SpO2 and oxygen rate requirements. If needed, I am going to supplement with oxygen. So I will stay with you and until the MDT teams arrives. So this is the way you are going to talk to the patient as part of escalation. Okay, the next one is this is the scenario. So for example, see what's going to happen is MER call. If 3 or more are the observation red zone, you have to go for a MER call. Okay. So in MER call, this is the purple color zone. This is the purple zone. So what's going to happen is, see, one or more of the observations are the purple. You straight away one or more is purple. Okay, so this is the purple, means something like a code blue in our system. So the emergency team is going to come in. It looks like a patient is not good at the moment, and patient is deteriorating. Sometimes patient may collapse or faint, or patient will go for arrest at this stage. Then the other criteria are, you are worried about the patient or the consumer is worried. Consumer means the next of kin, the family member is worried. This is applicable for every aspect. Patient or consumer is worried. See, patient or consumer is worried. So this is applicable for every scenario. And then one or more of the following are occurring. Okay, so there's a zonal response is there. On top of that, there is one or more of the following is occurring: respiratory or cardiac arrest, threatened airway, and significant bleeding, unexpected uncontrolled seizure, or delayed MDT review of more than 30 seconds. So if this happens, right away go for MER call. Place emergency call and specify location. So there is a button will be provided for you. You have to press that button and initiate basic and advanced life support. So you have to initiate basic and advanced life support. That means you have to go for PLS and ACLS, notify senior doctor responsible for the patient, increase the frequency of observations post intervention, and take advice from MER team. So this is the management here. Patient is unconscious, so usually this scenario will not come up in the Australian scenario. Okay, so if this is going to happen, this is usually happening along with the BLS, but this is not happening in case of A to G assessment, or this is not going to happen in case of vital signs. Okay, so you don't worry about that. This is where the patient is unconscious. You can't talk to the patient, and you can't figure out anything at this stage. You can't discuss anything at this stage because patient is unconscious at this stage. So this is the way you are going to, usually you will be getting one of this one, either yellow zone, or in the MDT review, that is a red zone, that this is the red zone over here, and this is the purple zone over here, and this is the yellow zone over here. So one of this one is happening, and you have to escalate the plan that I have discussed. We will go to the other side where you have to look for, there are guidelines will be there. Example, so I have told you, every time you are getting the chart, you have to fill up all these things. The demographic data are very, very important. If you are not filling up the demographic data, that is not considered as a completion of documentation, and generally you will be negatively evaluated. Okay. The next one is there are guidelines. These are the guidelines. Section A is general instructions, minimum set of observations in the section C, that is respiratory, toxin saturation, blood pressure, pulse rate, temperature, pain, and level of sedation you have to take. And other observations in this chart are oxygen flow rate and delivery method. Okay, and how to record the observation. So you place a dot over here in the center of the box that includes the current observation and its range of values. Connect a new dot to the previous dot with a straight line. So once you have it, you have to go with it like this way. You know, this is going to happen in usual ICUs. You know, that's you know yourself. The systolic and blood pressure, use a symbol that is indicated in the graphic chart. That means an inverted V that you have to use. Okay. Next one is a modification. I told you the modifications. A modification RMO, registered medical officer, or a senior doctor can make some changes in the observations. But if it is going beyond 24 hours, a consultant has to come in, and a consultant has to be consented. Okay. Then modification should consider ACD, and that means advanced care directive, and also 7-step pathway, this resuscitation plan. A nurse must countersign the modifications acknowledgement. A consultant must sign if the modifications are continued beyond 24 hours. Okay. So a nurse should sign. If nurse is not signed, there is no modification is going to work out. Okay. Changes in the usual frequency observations. Example, if requested by the treating doctor. Frequency, duration, and reason should be recorded in the section E. So example, you can code it as treated. Sometimes the doctor wants to change, or the patient is worried, or the patient or family is concerned. After the intervention, incident procedure, treatment, local procedures, okay, or MER call, until the observation and the normal range is defined by the zones of modification, terminal phase, and other. So you can put a code over there in that area where the section E, that is I told you the section E, you can date and time, and the reason means you can put a code over here. So this is the code you are going to put in this example, MER call. So you can call E over here and finish date and time and stuff like that. Okay. Then the next one is interventions and review. So once they are coming over here, you have to look for use for interventions and record for any MDT or MER call. Document any intervention or action taken in the response to changes in the observation. Example, use of space blanket. Example, space blanket means a strong blanket or a warm to a warm patient. Increase the pulse flow rate and give food to diabetic and concerns raised by the patient, family or carer, a new unexplained deterioration of the behavior or mental states. So all these things reassure the patient, all these things are there. It's simply you can read out all these things, okay. But I have to talk to you something about a resuscitation plan. This is called a 7-step resuscitation plan. It's written over here, 7-step. So 7-step resuscitation plan means there is a 7-step in which you have to initiate or complete the resuscitation plan. You have to formulate a resuscitation plan based upon 7 steps. That's another criteria, and I will look into that at some stage in the future, okay. At the moment I am going to talk about a 7-step pathway. Means there is a resuscitation plan has to be decided between the patient and the treating doctor and the nursing team. And there should be a plan, a written plan should be in place, okay, whether the patient have to go for resuscitation and a hospital transfer, whether the patient have to go for comfort measures, okay. So example, 7-step resuscitation plan is in place. If there is a resuscitation plan is in place, example, patient had active resuscitation and hospital transfer, or patient does not need any resuscitation, active resuscitation in case of heart arrest or cardiac arrest, so only comfort measures are needed. So if there is a plan in place, you can tick over here, or sometimes the families will be looking for, or patient will be looking for more time to decide. So that's called the that's in progress, that's in pipeline. So you can tick over there. There is no plan over there because patient just come in, or because some other reasons there is no plan, or sometimes respite patient will be coming for short admission or something. Sometimes there is no plan over there. On 7-step pathway resuscitation plan needs to review. That means presently there is a resuscitation plan is in place, but the example the family want to make a change in that one. Now the decision is patient is not for resuscitation, but the patient or the family want to go the other way. That means they want to go for a resuscitation and transfer the patient to a hospital. So there is a change in that's going to happen. Sometimes the patient will be very healthy, and there is another scenario in which a patient is active resuscitation hospital transfer, but patient is deteriorated grossly, and there is no point in sending the patient to the hospital for after resuscitation. In that case, there is no point in resuscitating. So there is a review can take place at this stage. So you can tick over here. In see, these are the main points. Then next one is advanced care directive. That means if the patient dies unexpectedly, what to do with towards the end of life. So how what treatment to be given, to be anointed, or somebody has to come in, who is going to take care, whom to be informed, who is the undertaker, where they have to go, how is committed, how is displayed. So all these things are there in the let's see if it is there. That's in the medical record or in my health record. That's a computerized documented system in the Australian way. If it is in the computerized system, you tick it on there. The next one is a patient who is end of life and is not for resuscitation may still require urgent medical response for symptom management. Refer to the current Mr. Resus Advanced Care Directive to instructions the patient's wishes regarding MER call, CPR or other treatment limitations. Other advanced care plan, if there, you can tick and you can write down there is an advanced care plan is in place. Example, patient has his own wishes for some other things. Example, patient want to donate his remains to a teaching hospital. Okay, so that's a plan. The patient wishes, you can go for, you have to go for that. So this is the way you are going to address that issue, where this is going to, because all these things are going to affect the plan over here. Okay, patient does not want to have a resuscitation and a hospital transfer and active management over here. So the plan will be changing accordingly. There are certain situations in which even if patient is not for resuscitation, patient needs active treatment. So patient is having pneumonia has to be treated. Okay, patient is having urinary tract infection, that has to be treated. Patient has Parkinson's, that has to be treated. But in case of the 7-step pathway resuscitation plan means if the patient's heart stops, that means patient's cardiorespiratory arrest happens, do we have resuscitate? So that is the only question. But the other management supporting measures and other treatment aspect will continue irrespective of resuscitation plan. That's the Western facility that's going to happen in UK, Ireland and Australia. It's pretty same. Okay, this does not mean that you are not going to treat the patient if patient is having urinary tract infection, where the patient is having a resuscitation plan in which a patient is not for active resuscitation. That's not going to happen. So I presume this is the way you are going to address the observation chart in the Australian vital signs station as well as in the A to G scenario station. I hope you have got an understanding about the vital signs station and A to G station, because I have already discussed all these things before, and go through these charts so that you can familiarize with this chart and you can perform very well in the OSCE scenario in Australia. If anybody is looking for OSCE training, myself Bimal, I am one of the lead trainers in MWT Global Academy in Kottayam. We are conducting face-to-face training on a regular basis from Monday to Friday, and there is an extended training program is available for other students as well, with very minimal rates than compared with the Australian rates. 1/10 of the Australian rate we are conducting the training for 1 week, and and for 7 days as well, so 8 days as well. Okay, so if anybody is looking for a training at any point of time, do contact us. Also, if you like this video, please like the video and share the video to your friends, those who are going for Australian scenario. My plan is I am going to continuously keep going with the Australian and then Irish and then UK scenario, because I'm a trainer training OSCE for UK, Australia and Ireland for nearly 2 years with 100% result. So thank you very much for joining with us, and if you have any queries, I will give you my number. You can contact with us. So see you next time with another informative video. Thank you.